All right, thank you everyone for coming. Thanks for waiting while we get everything set up. So today you can hear me all right?
Yeah.
We're gonna talk today about metastatic disease to the spine. You took my phone. Okay, so cancer is the second leading cause of death in the United States, and there's about 1.4 million new cases of cancer that are diagnosed every year. And there's 500,000 cancer-related deaths that happen each year. So basically, with all this cancer going on, oncologists, we're getting prolonged survival rates in these cancer patients, which is leading to patients living longer, and therefore they're more likely to get some metastatic processes, and that's why we're seeing more metastatic spinal disease. Basically, as you probably know, the lung is the most common place that metastases go to, the liver is the second most common, and the musculoskeletal system is the third most common site. And the axial spine is actually the most common musculoskeletal site to happen. And that's usually just based on the volume average of the medullary bone that's in the spine. And the thoracic and lumbar spine, 80 to 92%, that's where the spinal metastases occur. Cervical spine, a little less common, 8 to 20%. Now, the interesting thing about metastatic spinal disease is 80% of the patients that do die with metastatic cancer have some spinal involvement, but only 5 to 15% of people are actually symptomatic. So although we get a lot of consults for this, there's probably more people out there that have this. It's just a hidden thing that's going on that they don't know about. And then in addition to this, the metastatic disease, you can just get involvement of the vertebral body and stuff and such, but about 20,000 patients are going to get metastatic epidural spinal cord compression. So they're going to actually have the metastatic disease within the canal, causing some neurologic involvement. And you can get intradural metastases about 5% of the time, 90 to 95% of the time, the lesions that do press on the spinal cord and the nerve roots are extradural. And the most common disease processes that go to the spine are breast, prostate, lung, renal, and the hematopoietic tumors. So basically, when we have a patient that presents with spinal mets, there's three kind of scenarios. You can have somebody that has a known history of cancer and they have known metastases, or you're going to have a patient that has cancer but never knew they had metastases, or you're going to have patients that had no prior history that they even had cancer. So 12 to 20% of people that we see with METs, they're getting their first diagnosis that, oh my God, you have cancer. So it's kind of a very important milestone in their life. And I mean, it's not a happy diagnosis. So basically, what do we do with these people? If you know they have cancer and you know they have known METs, you don't really need much of a workup. You can basically look at the films, you see what kind of tumor it is. They don't need to biopsy it to re-diagnose it. You can just go forward with treatment. Now, the patients that have a history of cancer but no prior METs that present now with new metastatic disease actually should be re-imaged. You should work them up almost to a degree where they get CAT scans of the abdomen, pelvis. They might need a PET scan, and they might even need a new biopsy. Because, I mean, more likely than not, it is going to be that primary tumor, but there is an outside chance it could be a different tumor, a secondary type of cancer. So that's going to affect your treatment. So you do want to verify. And then the third patients, like we talked about, they don't even know they had cancer. They get diagnosed with this lesion and they find out they have a malignancy. So basically, if you do a good history and physical, routine labs, you get a bone scan and a chest, abdomen, pelvis CAT scan, 85% of the time, you're going to be able to figure out what their primary is. A lot of times we used to just jump right to biopsies, but just doing a large bore biopsy alone, 2/3 of the time, you're not even going to get the diagnosis. It'll be inconclusive. And the reason sometimes for that is lytic lesions are better to get biopsied than sclerotic lesions, because when you're going into a sclerotic lesion with one of these needles, you're destroying the tissue and you're not going to really get a good tissue sample to figure out what cancer they have. And the most common tumors that present as no history of cancer or malignancy are the carcinoma of unknown origin, the lung cancer, myeloma, and lymphoma. So presentation, a lot of times, like in orthopedics, people are complaining of pain. So the most common presenting symptom for us is 85, 95% of people are going to complain of pain. Now, they're either going to have they talk about these three classic pain syndromes, where you get local pain from the metastasis. The bone is a little weak. There's inflammation in the area affecting the small nerves in the area. So you get this aching, gnawing pain that's at the level of the metastatic process. But you can also get mechanical pain. If people have pain that's worse, with movement and activity, is there an impending pathologic fracture, or is there actually a fracture? And then you get radicular pain or neurologic issues, where you're going to get dermatomal pain. That's true dermatomal pain, and there may be a met pressing on an exiting nerve root or the spinal cord. And then, just like in training, you always learn somebody that has unrelenting pain, that's non-mechanical in nature, that's worse at night, you're supposed to have a high index of suspicion for some type of malignancy to begin with. And that's just one thing I just wanted to mention. So the second most common presenting symptom for these patients may be some motor deficit. I mean, it doesn't have to be, they're not going to be paralyzed per se, but they may have some EHL weakness. They may have a little quad weakness. There's usually some, if you're really pretty detailed on your exam, you'll pick up that there is some mild weakness. A lot of times we get confused. Is that really effort dependent? Is it true weakness? But it's something that we try to monitor and note. And then when we talk about bowel and bladder issues, it's usually bladder dysfunction that's going to be the most common autonomic finding that you see. And this usually relates to the degree of motor deficit they have, because the more compression, obviously, you have on the neural structures, the more likely you're going to get some bladder dysfunction. So what do we want to do? Obviously, you need a good detailed exam of the spine. You want to palpate, push on their cervical, thoracic, lumbar areas. You want to get a good neurologic exam. You want to check their motor strength, their sensation, even their proprioception can help let you know if there's more compression posteriorly versus anteriorly. Then, knowing about their reflexes. I do usually like to try to order a complete spine x-ray, although we know x-rays don't show a lot, but 15% of people are going to have non-contiguous METs. I mean, unfortunately, most of the time when we get these consults, they already have an MRI, but sometimes if we're looking at x-rays and we're suspicious, it might be nice to get, all levels. And then also, since these patients do have a history of cancer, their overall health status is really important in trying to determine their treatment. If they're very cachectic and they're not mobile, they may have a decubiti, they may have lung cancer, they may have some pulmonary compromise, they may have other ascites and liver dysfunction. So if they're not that healthy, you're not going to be thinking about surgery, if you can avoid it. And then just basically when you're looking at the plain x-rays, the classic winking owl sign, it takes about 30 to 50% bone loss to actually see something on a plain x-ray. And that's just that classic picture where it kind of looks like the guy's winking there, right? You can see the picture in the middle, missing the pedicle. So CAT scans from an imaging standpoint, CAT scans are usually pretty low, 66% sensitivity to actually see METs. I mean, although CAT scans give you great bony anatomic detail, which can let you see what's going on, it's not going to really, you're not really picking up. A lot of times you're not sure if it's a MET, so the sensitivity is not there. As we know, MRIs give you the greatest sensitivity and specificity for detecting spinal METs. And usually you're going to look at the T1 and the T2 are the most important. You can also look at the STIR images. And the thing that we always do, we always order gadolinium when we're looking at METs, but you're really not looking to look at the bony detail when you get the gadolinium, because intraosseous METs, it doesn't make a difference. You're going to see that. You might get the CAT scan to see the detail. But the gadolinium is important for looking for soft tissue extension. Do they have an epidural mass that might be causing some compression? Is there any, the leptomeninges, is there any kind of enhancement of that to suggest that there is some more tissue involvement in the neurologic system? And this is just a little slide. The first column there is the T1, and you can see it's, metastatic disease, low on T1. So you see those two bodies, they're pretty low in image intensity. And then you go to the T2, which is in the central portion. It's kind of increased on T2, similar to the CSF. So that right there, you're thinking, oh my God, it could be tumor. And then the last slide, the last column there is actually the gadolinium. And you can see, that there's definitely the cord compression behind that fracture, and but there's not any extension. You don't see, we don't have the axials here, but just on that quick view, you can kind of see that it enhances on gadolinium as well. So basically, what we want to know is when we know someone has METs, we're trying to determine, what's their prognosis. Unfortunately, just looking at them clinically, it doesn't give you a great survival rate prediction with these patients. And the sobering point of this whole thing is only 10 to 20% of people that have spinal mets are likely to be alive in 2 years. I mean, it's a small number. I mean, there are people out there, breast cancer survivors and stuff, but people that do present with mets, especially if they're extensive, there's a high mortality rate. So there was this retrospective study that was done by we can never say this guy's name, Takahashi. So basically, there's a whole little laundry list of things. So you look at this Karnofsky performance scale. It's how active is the patient. So the less active you are, the lower your score. So if you get, a 0, 1, or a 2. But then they also look at extra spinal bony metastases if you have something in the femur or the humerus or the rib. So if you have that, you get more mets, you get a lower number. Then there's how many vertebral bodies might be involved, you get a lower number. And basically, the lower the number, like we said on that previous slide, if you're getting a 0 to 8, your survival rate could be anticipated less than 6 months. If you're getting 9 to 11, you might live a year. If you're getting 12 to 15, you could be a year. So basically, we look at all those things. It has a little bit of the type of tumor, because obviously some tumors are more aggressive, and obviously the neurologic status. If they are paralyzed, that's a bad indicator. It's a bad, so you get a low number, 0. So obviously that translates to a poor survival rate. So now in the management, the main treatment of metastatic disease is palliation. We're not doing a lot of surgeries on people that have metastatic disease unless indicated. But, most of the time, people are going to get some kind of chemotherapy or biologic treatment to try to help slow down their tumor. Giving steroids, we always give steroids for various things when we talk about spine issues, but tumor-associated inflammation gives you actually some analgesia. You can get improved neurologic symptoms because you're going to reduce cord edema. And you could also, certain tumors like lymphomas and myeloma, actually steroids can kill the tumor cells. So actually they get a little kind of, help that way. And then there's been studies out that there's no real optimal dosing regimen. Like I know I always do the 10 milligrams of decadron and we do a taper over a couple of days. There've been some people that just do a huge 100 milligram bolus and then give a small dose of decadron for a couple of days every Q6 hours. And there's no real improved benefit in either one of those scenarios. So people just pick what they feel comfortable with. I think you get less GI issues if you start with the lower numbers, obviously. So that's why I've stuck to that. And then radiation therapy, that's a huge kind of treatment option with people with metastatic disease. Almost everyone gets radiation therapy at some point, unless people are going to undergo like a huge tumor resection. If they have let's say a solitary lesion somewhere that we think we can kind of make them disease free and we're going to do a big procedure, you're not going to do radiation because that's going to damage the tissues and give you some post-op complications. Also, people that have really radiosensitive tumors, super radiosensitive tumors, may not need chemosensitive tumors are not going to need the radiation. And radiation, typically, the conventional XRT is going to be in several fractions, and they give them up to a certain dose. And basically, the limiting factor for the radiation is the spinal cord and the kidneys. Those are the two most radiosensitive organs. And obviously, the spinal cord, you don't want to cause any paralysis, because if you over-radiate, you're going to get some issues that way. But now there are some newer stereotactic radiosurgical techniques called SRS. That's like the Gamma knife and the Cyber knife and the Novalis. And basically, you can give a much higher dose in a lesser area, so you get less exposure to the surrounding normal tissues, and you can do less treatments. And it's usually better for radio-resistant tumors because you can give such a high dose in a concentrated area that you're able to kill some of the tumor cells. So I don't have a lot of experience with that myself. That kind of started out a lot later after I was done with, out of training, but that is definitely an option. And then a little bit about, the radiosensitivity of some of these tumors. Obviously, the lymphomas, the myelomas, seminomas are really radiosensitive. Those get radiated a lot. The breast cancer, prostate cancers are usually in intermediate sensitivity, and the solid organ tumors like the renal, liver tumors, they're pretty radio resistant. So from a surgical standpoint, people do at times need surgery as well. And initially, when people had tumors and they presented, they did posterior laminectomies. That was the mainstay of treatment. And that gave pretty uniformly poor results alone. Because if you have as we always see, most of these tumors are anterior vertebral body. They're destroying the architecture. They're making the anterior structures weaker. And then we're going in the back doing a laminectomy. So we're removing really the only posterior stabilizing structures, allowing that weaker tissue in the front to have to bear the load. It's more likely to progress. You're only getting an indirect decompression when you do a posterior decompression. But before anterior surgeries became in the vogue to do for these kind of tumors, they did posteriors. They didn't see good results. And that's why years ago, it used to be everybody that had a metastatic lesion got radiation. They didn't even have a surgical consult. They just say, oh, you need radiation. But as we had advances in surgical technique and different instrumentation systems, people started to do more surgeries. And then there was this study, I forget exactly what year it was, I think it was 1995 or so. But this study basically, the XRT alone versus surgery, and then 2 weeks later doing some XRT. And I mean, the thing that I thought is the most striking was the non-ambulatory pre-treatment patients. So you did this XRT alone. Some people do regain that ambulatory status, but 19% is not a lot. Whereas the people that had the surgery and the XRT, 62% of those people that couldn't walk were able to walk. Basically, the mean survival rate here wasn't great because these were pretty sick patients actually that they did this when they did this study. But the numbers in general did point to, in the right hands, that surgery with some XRT, if there is neurologic involvement, is a good treatment solution. So the indications for surgery, I mean, the number one indication would be progressive neurologic deficit. So if someone's developing paraparesis or something along those lines, they're going to need, you got to think surgery. Spinal instability is another big one. If you have spinal instability, radiation isn't going to do anything. You got to stabilize it. You got to put hardware in there, and otherwise they're just going to progress again into neurologic problems. If there's cord compression from bone rather than tumor, some people say that also is, you're not going to be able to shrink the bone. You're going to shrink a tumor if you do the chemo and radiation and stuff. So if there is true compression from a big bony lesion from a fracture, that's not really tumor. It may be wiser to think about surgery sooner than later. Metastatic epidural cord compression from a radio-resistant tumor, that's pretty extensive. That might be too much for, say, SRS, the stereotactic gamma knife type of stuff. Maybe better to think of surgery. People that have recurrent metastatic epidural spinal cord compression after they've been through XRT, you can only get certain amount, again, because of the radiosensitivity of the spinal cord. So they may be more opting for surgical intervention. And sometimes just unrelenting pain, if they just have pain that everything's been given and they're not getting any better and they're not having neurologic deficit. Sometimes if they have a good life expectancy, we'll talk about surgery. And on the rare occasion, tissue diagnosis, we can't get a tissue diagnosis and there is significant compression. You don't see that a lot, but that was one of the recommendations for possible surgical intervention. And again, like I said, almost all these people, if they do have surgery, you wait the 2 weeks. You don't do it. You usually don't do radiation before you're going to do surgery because you'll get wound complications. Usually it's better to do the surgery, give the tissues 2 weeks to heal, even a little longer if you can, and then thinking about doing the radiation therapy. And then when we think about surgery, there's a lot to think about there too. You got the approach. Where is the tumor? Most of these tumors are anterior, but you can have a posterior tumor. You can have a tumor, that's a little more left-sided, right-sided. So you got to see what's my approach going to be. If it's in the cervical spine, I may be able to do a simple anterior approach. Going into the thoracolumbar junction or the thorax can be pretty devastating for patients that have metastatic disease. So again, when we talked about their overall health status, if they're deconditioned, they're not going to be able to tolerate that procedure. So you always got to take that into consideration. You don't want to offer them surgery and they're going to die because they can't tolerate the surgery. So we have been these newer posterior transpedicular approaches. You can actually try to remove the pedicle from the posterior and then try to debulk that tumor. And then now that we have SRS, they say you don't have to go crazy getting all the tumor, because then you can try to do one of these kind of isolated SRS things to try to radiate that tumor, so that if you debulk it to save neurologic function, you can kind of improve their outcome a little bit by doing some radiation too. And then one thing you got to think about too in the preoperative plan is you have thyroid tumors, renal cell tumors, and melanomas are very vascular. So if you know you have a vascular tumor from your tissue diagnosis, you might think about preoperative embolization. So surgery, again, like we said, the preoperative medical optimization is important to prevent any surgical complications. Postoperatively, they need nutritional support because it's usually fairly extensive surgeries that people are going to need, whether it's anterior or posterior. So you want to give good nutrition so that they can heal up. On the lesser side of surgery, vertebroplasties are an option. If it's really truly just a pain issue and you think it could be like an impending type fracture, pain-related phenomenon, and there's no neurologic deficit, no gross instability, people do well with vertebroplasties. There's a study by Forney that they did like 100 patients, and 84% of these patients all showed pretty significant improvement in their pain. 9% of people didn't show any improvement, and there were really no major complications. But the only thing with vertebroplasty, there's some people that you can't, the poor candidates. If you have greater than 75% vertebral height loss, if you've got greater than 20% canal compromise from epidural disease, if you have any breach in the posterior wall, all that stuff is bad. The cement can extravasate into the canal and cause more issues, so that you're not really a candidate. If you have more than 3 levels, the more levels you have to do, the less likely they're going to get better. And if you have an uncorrected coagulopathy because they are metastatic disease and they don't have good liver function and they're not making their clotting factors. And then there's a newer thing, like we used to always talk about when we talked about spinal instability. We'd say, well, if we see greater than 50% destruction of the vertebral body, it was very subjective on when you would say they had instability. But there was this new spinal instability neoplastic score that basically there's a lot of different things to look at. But the main thing at the end of it is if you got 0 to 6, chances are pretty strong that you're not going to need surgery. So it's kind of a simple thing that you can look at sometimes. And then basically if you're 7 to 18, obviously the higher you go, the more likely you're going to need surgery from an instability standpoint. But the things they're looking at with this are actually, where is the tumor? Is it in a rigid part of your spine, like the sacrum or the thoracic spine, or is it in a more mobile part, or is it in a junctional area? So if you have tumors in the junctional area where there's more stress, it's more likely that there may be some instability, because the disease process is going to sacrifice the stability. I mean, basically you ask people, do you get pain relief with recumbency? Do you have more pain when you're moving? So if there's definitely a yes there, you get more points, which isn't good. If you get none, no mechanical pain, you're getting less numbers. So you want to ask that. And then also the type of lesion, like we said, blastic lesions, the bone is not actually weaker. There is tumor there, but they're not destroying the bone. The bone is still pretty strong, so you're less likely to have an instability pattern. Then the alignment, do you have like a spondylolisthesis to suggest that there is some instability there? So that gives you more points. The percent of vertebral body collapse. And then also if there's bilateral involvement, if the pars on both sides or the facet joints on both sides are involved, then there's more likely to be instability. So if you kind of run through all that with talking to the patient, looking at their x-rays, and you get a number, you can be pretty comfortable that, surgery, non-surgery kind of thing, if they do have a good life expectancy that you think they could tolerate a surgical procedure. So basically, the management of spinal metastatic disease is pretty complex. It's a multidisciplinary approach that you need. And the goal is, like we said, palliation. A lot of times it's not going to be a cure. But you need to individualize these treatment options based on the specific presentation of the patient. So that was a picture I showed you about just looking at a tumor. T1 is low, T2, and then the contrast. But this here, so I just have this little slide. So you do see that posterior vertebral body wall. I always tell you guys how if there's a little convexity, you could start thinking tumor. So is that really convexity? Then there's a little bit of enhancement there with that little kind of decreased signal intensity below it. But the trick here is just a fraction. This is not tumor. I mean, I know we don't have all the different imaging studies to look at, but basically, we're looking at, the T2, because you can see the fluid in the CSF, and there is a little bit of fluid there, but the whole thing, that area of low signal intensity shouldn't be there. If it was a tumor, the whole thing would light up. So this is just to kind of show you that, make you think a little bit. So then this is cervical spine. Obviously, you can see it has the convexity. There's a large mass there. This is a tumor, in the cervical spine, which you might consider with the cord compression. Are you going to need to go anteriorly and do something surgical? The pictures aren't projecting. I can't see them. This one?
Yeah.
A little better?
Definitely.
That better? Sorry. Oh, that's good. Oh, I see. All right. So then this is just a quick little, so there's up at the top by A there, you can see that's T2. There's a little bit of increased enhancement in the posterior vertebral wall. It looks like it could be a little convex. And then there does look like there's even some posterior behind the spinal cord. There may be some enhancement there. It was just a T2. This is all I had here. But then on the B cut there, you can see that's the MRI. And you can see the tumor on the right side there in the facet joint region. There's a big soft tissue mass. And then you can kind of see the spinal cord being pushed over to the left by that soft tissue epidural mass. I mean, treatment-wise, D. So basically what they did was they did a posterior decompression, and then they did instrumentation to stabilize that segment. This was a radio-resistant tumor. The C picture is just a CAT scan that can show you how the spinal cord went back when they did that debulking. And I think that this wasn't one of my cases, but this patient did go for some SRS afterwards. So basically they debulked a lot of the soft tissue tumor, stabilized it because it was a radio-resistant tumor, and then did some SRS. And supposedly the guy did pretty good. Actually, he beat the 2-year thing for, I think they said he was 3 years. As a friend of mine did this. Now this is a patient that presented. You can kind of, you see she has scoliosis. You see the X-ray. There's the deformity there. I mean, it's really hard to see it. There's actually a vertebral body that's missing in between the two vertebral bodies, where all that sclerotic bone is and where the staples are anteriorly. All that that has nothing to do with the surgery. That I think she had some pre-abdominal surgery before. But on this picture, you can see on the lateral, one of those is an extension and one is neutral actually, but there's a body in there. You can see it a little better on this flexion view. You can see how there's just that little triangular piece left. So basically she's got some significant deformity there. And then on that MRI, you can see the T1 on the left, there's tumor in there in those two vertebral bodies. On the T2, unfortunately here, this lady had a bunch of radiation therapy. This was actually a breast cancer patient. So what happens is when you have an extensive radiation history, the normal vertebral bodies get fatty marrow replacement, so they look white. So you're kind of looking, you're saying, oh, what the hell, is that tumor or not? Or she has tumor in all those other bodies as well. But you don't have those signals. There is a small focus in like the L4 there. You got that on the left side there where the T1 is. You can see there is a little bit of tumor there. But it didn't really, it's hard to see the enhancement because of the previous radiation therapy. But she was unstable. She had some neurologic involvement with radicular pain. So we wound up doing, getting 2 levels above it, 2 levels below it, tried to debulk that tumor as best we can. And basically she did pretty good for a while. But unfortunately, this lady just passed away yesterday. This was Brenda Smith.
Oh, no.
She died, 2 days ago. Yeah, the family called me. But she did. It was almost 2 years. She had a little more complicated. She had a post-op infection, unfortunately, because of her radiation therapy. Her skin in the back wasn't so good. But yeah, she did. And that was it for a spinal metastatic disease. I know it's just so kind of little depressing topic. But, any questions anybody has? Nothing? Okay. Well, we were talking about, we do see a fair bit of epidural abscesses, and I tried to get some pictures together, a couple of x-rays again. Just a quick little synopsis. it 1 to 2 out of 10,000 inpatient admissions have some kind of a spinal infection, whether discitis or an epidural abscess. There's a male predominance, diabetes, immunocompromised, alcoholism, old age, IVD-aid, and hemodialysis are all risk factors. Trauma or invasive spinal procedures can also be a predisposing factor. And then we got, spinal decompression and antibiotics are usually the standard of care. So this is just a picture. So this is a lady that had previous instrumentation. That's why the pictures kind of look a little cruddy. But if you look up on the left there, you can see fluid in the disc space. And then if you look on the other side, so this is different than tumor, right? Because so this is T2, but you got fluid in there. And then when you go to the T1, I know these pictures don't project well, but there is this decreased enhancement. You don't see the anatomy that well. And that usually is what you're going to kind of see, although it kind of looks like tumor. In tumors, the discs always look pretty good. So a lot of times the infections start at the disc level. So you kind of want to look. If the discs look relatively spared, chances are it's tumor. If the discs are pretty nasty looking, you start thinking infection. So this is actually a true epidural abscess. So this guy, you can kind of see like there's some fluid there, right? You kind of see something like, you can see the fecal sac here, but then there's something here and it goes all the way up here, so that kind of there, and there's a little bit of fluid in the disc, so maybe it's starting here. He's got a disc here, but there's that fluid, that could be infection, and it goes all the way down. And then when you look at T1, you kind of get the vague sense that there's something there. It's usually iso intense to the spinal cord, so it's kind of hard to see. If you get contrast, you'll see it a little better. I didn't have any of the contrast images on this one. I couldn't find them. But basically, that's what you're looking for. And the one thing I always tell people is, so on the axial, you could see that left-sided collection. That's pus, kind of right through here. And then what you want to do is, I was trying to get this picture to expand. A lot of times people have psoas abscesses when they have these infections. And if you don't look for it, a lot of times you may miss it. And this guy did have a psoas abscess, and I was trying to get the picture, but I couldn't get it to, when I was trying to format it for the talk to show that. But that's an important thing to look for. But those are just some of the slides on the abscesses. Any questions about that?
And should we be getting like an MRI with GAD often?
Like for which now?
Like in general, like you have a patient, I guess it depends if you're looking.
Yeah, like if they have had previous surgery, you always want to get right with GAD because you want to be able to distinguish scar tissue. I mean, if you're thinking tumor, like we said, the tumor, it's important more for the epidural extension, not so much for the bony portion of it. Yeah. For infection too, it helps, for just highlighting, the.
I feel like we don't often get with GAD.
Yeah.
And they're usually the renal.
Right, you gotta. Yeah. That kind of comes into play. So, I mean, sometimes it's kind of painful, but a lot of times if you're not sure, you get the initial study, and then if you're suspicious, you can send them back. I mean, or is it better to just do the with and without and have them get it as long as their renal function's good?
If MRI is not an option, then contrast CT.
Right, like for study. I mean, more like for tumors and stuff for sure. Yeah, because then you'll see if there's any cord compression. You can see the anatomy a little better. Okay. Down good. I hope that was helpful.
Do you usually decompress posterior, like somebody like this with the psoas abscess? Do you have IR place to drain, or do you?
I know, like with a big collection like this, I mean, we definitely needed to drain it just to get it cleaned out.
Yeah.
And then but I do usually have IR do the psoas. Yeah. Right. Exactly. Well, thank you, and I hope we're done. Anybody else listening out there?